So imagine you take a teenager to the emergency room, right?
Yeah.
And they have this severe, totally life-threatening fever.
Mm-hmm.
The doctor takes one look at them, hands them an ice pack to cool down, and just sends them home.
Wow.
Completely ignoring the massive underlying bacterial infection
Yeah.
that's, actually causing the fever in the first place.
Right, which would be completely unacceptable.
You'd be furious. I mean, it sounds like absolute malpractice.
He does.
But according to the clinical data we're looking at today, that is essentially what standard psychiatry is doing to teenagers with complex mood disorders, like every single day.
It's a staggering reality. It really is. We trust these medical systems to be thorough.
Yeah.
But when you step into the world of adolescent mental health, that thoroughness it often hits a brick wall.
A wall of what? Scheduling?
Exactly. Scheduling limits and just massive systemic blind spots. We're dealing with this diagnostic landscape that is entirely murky.
Right.
The symptoms are incredibly loud, but the root causes are, they're incredibly easy to miss.
Welcome to the Deep Dive. Today we're analyzing a really fascinating stack of sources. We've got clinical review notes, diagnostic screening protocols, and some incredibly detailed operational blueprints.
Yeah, the operational stuff is fascinating.
It really is. Our mission for you today, whether you're a parent trying to navigate a crisis, an educator, or just someone intensely curious about modern psychology, is to unpack the critical difference between normal teenage angst and an actual clinical mood disorder.
Which is a very fine line sometimes.
Totally. And from there, we're going to look at a highly specific case study. It's a school-based telehealth model in Georgia called MentalSpace School.
Right.
We want to understand how models like this are attempting to bridge the terrifying gap between a mental health crisis and, actual sustainable stability.
Because the stakes here really are life-altering. We're talking about the trajectory of a young person's brain development.
Yeah, it's huge.
The difference between catching a subtle behavioral pattern and missing it entirely well, it can dictate whether a teenager successfully navigates high school or, honestly, ends up chronically hospitalized.
Okay, let's unpack this. Because before we can even begin to look at systemic solutions or telehealth logistics, we have to define the core clinical dilemma from our sources.
We have to know what we're looking for.
Right. We need to talk about the tightrope of teenage moods and why it's so incredibly difficult to spot when a kid is actually falling off that rope.
So the material draws a very stark contrast between typical development and dangerous pathology. It points out this specific cycle that caregivers really need to look out for. It's this extreme pendulum swing.
Like how extreme?
Well, on one end, the teenager feels like absolutely nothing can slow them down. It's a state of boundless, almost chaotic energy.
Okay.
And then seemingly out of nowhere, they hit a wall where they physically cannot get out of bed.
Isn't this like driving a car where the accelerator is just stuck to the floor?
That's a good way to put it.
Like you're speeding out of control, you're weaving through traffic, and the only way the car finally stops is if you completely blew the engine.
Right.
And then you just end up stranded on the side of the road.
The accelerator analogy gets us close, definitely. But I'd argue it's actually messier than just speed.
How so?
Well, when we talk about that stuck accelerator, the manic or hypomanic phase, it doesn't always look like classic productive energy.
Oh, interesting.
Yeah, it's often extreme irritability or aggressive risk-taking or a sudden massive deficit in the need for sleep.
Wait, like insomnia?
Not exactly. With insomnia, you're tired but you can't sleep. Here, a teenager might sleep 2 hours a night for a week and still feel completely wired.
Oh, wow.
Yeah. And when the engine finally blows, like in your analogy, that depressive crash isn't just sadness.
Right.
It's a profound, paralyzing inability to function. They literally can't move forward.
I have to play devil's advocate here, though.
Yes, sir.
If a teenager is sleeping 2 hours a night, screaming at their parents, and then crashing for days, I mean, how does a parent miss that?
It's a fair question.
Like, how does that not immediately trigger massive alarm bells in the house?
Because teenagers are already navigating a storm of hormonal changes and neurological remodeling.
Right, the whole teen angst thing.
Exactly. Society basically tells parents, welcome to the teen years, strap in.
Yeah, just deal with it.
Right. So when a teenager is incredibly moody or stays up all night gaming, society gives parents a very convenient excuse. They say, oh, it's just hormones.
It's normal teenager stuff.
Yes.
Yeah.
But our sources emphasize a core philosophy here. Accurate screening isn't meant to terrify parents.
Uh-huh.
It's meant to empower them to look past that hormone excuse.
Because if you write it off,
Because if you write off a clinical mood cycle as just bad behavior, you leave that teenager trapped in a vehicle they cannot steer.
and the toll that takes on the family is just brutal. I mean, reading through the clinical notes, you can literally feel the exhaustion.
Absolutely.
Loving a kid with these extreme cycles drains the entire household.
Yeah.
But the sources are also very clear. The parents don't have to navigate this in a vacuum, right?
No, they don't. The medical system does have tools.
But as we teased at the beginning of the deep dive, the system also has some massive, dangerous blind spots.
Which brings us to the structural failure at the heart of the clinical data, the 15-minute trap.
The 15-minute trap. I honestly read this section 3 times because I couldn't quite believe the implications.
It's pretty shocking.
The notes state that standard 15-minute clinical evaluations routinely miss a patient's hypomanic history.
Routinely.
Meaning, a kid gets admitted to a clinic or an ER for severe depression. They are at rock bottom.
Right.
And because the evaluating doctor only has 15 minutes, they completely miss the manic stuck accelerator side of the cycle.
Yes.
I mean, I understand doctors are busy, but how do you miss half of a mood disorder?
What's fascinating here is that the miss is almost entirely a product of systemic design. It's not doctor incompetence.
Okay, explain that.
Think about the reality of a modern psychiatric evaluation, especially in an ER or hospital setting. The clinician's immediate job is triage.
Just putting out the biggest fire.
Exactly. They have to assess for immediate safety. Is the patient a danger to themselves right now?
Right.
Add to that the pressure of high caseloads and insurance billing codes that often restrict intake times.
Oh, the 15-minute billing window.
Yes. That clinician is forced to treat the crisis that is sitting right in front of them in that specific moment.
And the crisis sitting in front of them is the blown engine. It's the depressive crash.
Exactly. They see a teenager who hasn't eaten in 2 days and just can't stop crying.
Yeah.
They do not have the luxury of time to explore the previous 6 months, to ask if there were weeks where the teenager was hyperverbal and sleeping 3 hours a night.
Wow.
So the clinician makes the most logical diagnosis based on a 15-minute snapshot, which is unipolar depression.
But the reality for that specific teenager is bipolar. And this is where the medical intervention actually becomes dangerous, right? Because treating bipolar disorder as if it's unipolar depression isn't just ineffective, it can be actively harmful.
It can be catastrophic.
Really?
Yeah, and it comes down to the mechanism of how certain antidepressants work in the brain, specifically SSRIs.
Okay.
An SSRI is designed to keep more serotonin active in the brain to elevate a depressed mood.
Which sounds good if you're just depressed.
Right. But if you give that to a brain that is already prone to hypomanic spikes, a bipolar brain, you aren't just bringing them up to a normal baseline.
What are you doing?
You are pouring gasoline on a fire.
Oh my God.
The medication can induce a severe manic episode. The brain gets flooded, and the patient's behavior becomes vastly more erratic and dangerous than before they even sought treatment.
That is genuinely terrifying. So the parent finally gets the kid to a doctor, they get a prescription, and the prescription makes the invisible problem 10 times worse.
All because the system was too rushed to ask about the kid's history.
That is the exact trap.
It is, but the clinical notes do provide a highly specific, very practical solution to this.
Thank goodness.
And it isn't some $1,000 brain scan. It's literally a 2-minute free questionnaire.
The MDQ, the mood disorder questionnaire.
Yes. The clinical recommendation in the text strongly advises adding an MDQ-style screener to the standard discharge materials for any adolescent admitted for depression.
Should they hand it to him on the way out?
Basically, yeah. It is explicitly designed to catch what that 15-minute evaluation misses.
But wait, so what does a 2-minute test actually do that a highly trained psychiatrist can't? Like, are the questions just that much better?
It's not that the questions are better than what a psychiatrist could ask. It's that the questionnaire actually remembers to ask them every single time. It acts as an objective net.
Right, it doesn't get rushed by the billing code.
Exactly. It asks direct historical questions. Things like, has there ever been a period where you felt so good or hyper that other people thought you were not your normal self? Or have you ever had a time where you got much less sleep than usual and found you didn't really miss it?
So it forces the teenager, or the parent filling it out, to look backwards,
Yes.
not just at how terrible they feel today in the hospital, but at the entire landscape of their behavior over the last year.
Precisely. And by capturing that hypomanic history, the clinician suddenly has the full picture.
And they can change the treatment.
Right. They can pivot away from an SSRI and look at mood stabilizers instead.
Which is huge.
It's massive. The text points out that utilizing this simple tool, which, by the way, listeners can actually see an example of at chicktherapy.com mental health tests, dramatically reduces the risk of post-discharge relapse.
You stop treating the fever with an ice pack and you start treating the infection.
Exactly.
Okay, so we identify the diagnostic gap and we have the MDQ screener to bridge it. But identifying the problem is only half the battle.
So
Because once you finally have the right diagnosis, you have to actually deliver the care.
Yeah.
And frankly, the logistics of child mental health care in this country are a nightmare.
a total nightmare.
You wait 4 months to get off a referral list. Then you have to pull your kid out of AP history at 11 a.m. on a Tuesday.
Right.
You burn an hour driving across town. I mean, the friction is just massive for families.
This is where we transition from clinical theory to the realities of execution.
Yeah.
The operational blueprints we're reviewing for MentalSpace School offer a case study in how to completely dismantle that logistical nightmare.
Here's where it gets really interesting. MentalSpace School is a K-12 mental health support model built specifically for Georgia schools.
Yes.
And they are bypassing the waiting rooms and the crosstown drives entirely by meeting the kids exactly where they already spend 8 hours a day.
In the classroom.
In the classroom. We are talking about same-day teletherapy. But honestly, as I was reading this, my immediate thought was, how does that actually work in practice?
Logistically, you mean?
Yeah, without completely violating a student's privacy. Like, do they just drag a kid out of math class with a megaphone and hand them an iPad in the hallway?
Well, no, thankfully. But that's the primary logistical hurdle of school-based care, and it requires navigating a very complex legal web.
Right.
You have FERPA, which is the federal law that protects a student's educational records, so their grades, their attendance, their disciplinary history.
Sure.
And then you have HIPAA, which protects their private medical records. Historically, schools and doctors exist in separate silos because mixing those two types of data is a complete legal minefield.
Right. I mean, a teacher shouldn't necessarily have access to a student's psychiatric notes.
Exactly.
And a doctor doesn't need to know the kid failed their biology midterm.
But MentalSpace School has essentially built a secure, compliant bridge between those silos.
So.
The operational details show a system where dedicated, licensed therapist teams are assigned directly to specific schools. When a student is in crisis or needs a session, there is a coordinated handoff. They go to a designated, private, safe space within the school building.
Oh, so not the hallway.
No, very private. And they connect with their therapist via a secure telehealth network. It is entirely HIPAA and FERPA compliant.
That's amazing.
Yeah, the medical privacy is maintained, but the school counselor is kept in the loop regarding the student's safety and general well-being.
So it creates a closed loop of care.
Yes.
And the sources point out that this care is actually coordinated with pediatric psychiatrists for full bipolar evaluations if that MDQ screener raises red flags.
Right.
It removes what is arguably the heaviest burden on a parent in these situations, which is just project management.
That is a critical point. In traditional healthcare, a parent with a struggling teenager becomes an unpaid, full-time medical project manager.
Oh, cool.
They have to play a game of telephone between the primary care pediatrician, the school counselor, the private therapist, and the psychiatrist.
Usually while trying to hold down a full-time job themselves.
Which is pretty much impossible.
Yeah.
By embedding the service within the school ecosystem and tying the therapeutic teams directly to psychiatric support, MentalSpace takes that burden off the family.
So the pros just talk to the pros.
Yes. The professionals talk directly to the professionals. The parent is kept informed, of course, and they even offer family counseling.
Nice.
But the parent doesn't have to be the primary conduit of medical information anymore.
It sounds almost utopian on paper.
It really does.
But, great ideas and slick operational blueprints don't mean anything if the people who actually need the help can't afford it, or if the program doesn't produce tangible results.
Right.
So let's pivot to the hard data here. Does this school-based telehealth model actually work?
The outcomes recorded in the data are incredibly robust. We aren't just looking at self-reported feelings of wellness here.
What are we looking at?
We are looking at hard, functional metrics.
The numbers that jumped out at me were an 89% improved attendance rate and a 92% reduced anxiety rate.
Those are staggering numbers.
Let that sink in. A 92% reduction in anxiety for students utilizing the program.
Wow.
But the part that makes this model a true paradigm shift, in my opinion, is the financial accessibility.
Absolutely.
The services are widely covered by major commercial providers. They take, BCBS, Cigna, Aetna, UHC, Humana, Peach State.
All the big ones.
Right. But for Medicaid patients, the cost is literally $0.
And that financial accessibility is the exact mechanism that drives that 89% improvement in attendance.
If we connect this to the bigger picture, help the listener understand that mechanism.
Right.
Like, how does a $0 Medicaid cost directly translate to a kid sitting in their seat during first period?
It comes back to the concept of friction that we discussed earlier.
Okay.
When a family is on Medicaid, they are, almost by definition, navigating profound systemic stress and financial barriers. In a traditional model, if a mental health appointment requires a $40 copay, or it requires a parent to take an unpaid afternoon off from an hourly job to drive the kid to a clinic, the friction is simply too high.
It's just not going to happen.
Exactly. The appointment gets canceled.
Mental health care basically becomes a luxury they literally cannot afford.
Right. And when the appointment gets canceled, the child's mood cycle goes untreated, the accelerator stays stuck, or the engine stays blown.
Yeah.
And what happens when a teenager is paralyzed by an untreated depressive crash?
They don't go to school.
They don't go to school. Their attendance plummets. They physically cannot get out of bed, just like the clinical literature warned us at the very beginning.
But when you remove the financial barrier, $0 for Medicaid,
Yes.
and you remove the geographic barrier by putting the therapist on an iPad down the hall from their homeroom with same-day access, you let the treatment actually happen.
You allow the intervention to work.
Yeah.
The mood stabilizes. And the direct, measurable, real-world result of a stabilized mood is a teenager who can finally get out of bed, walk through the school doors, and reclaim their education.
That is powerful.
That is exactly why the attendance improves by 89%. It isn't just a win for the school district's funding metrics.
Right.
It is a profound functional victory for that student's life.
It really is incredible to see how fixing one seemingly small logistical broken pipe, like how a kid physically accesses a therapist, can just flood a community with positive outcomes.
It changes everything.
For any educators or parents listening who want to explore this kind of partnership or intake, the sources list MentalSpaceSchool.com as the hub for that. Or you can reach them at mentalspaceschool@kichitherapy.com.
That's great.
It kind of brings us full circle today. We started out looking at the terrifying, chaotic difference between normal teenage angst and a clinical mood cycle.
We did.
We uncovered the systemic danger of the rushed 15-minute clinical evaluation and how prescribing the wrong medication can pour gasoline on a bipolar fire.
And then we explored the elegant simplicity of a 2-minute MDQ screener to catch what those rush doctors miss.
And finally, we saw the tangible proof that when you integrate care directly into schools via telehealth and remove the financial friction for families, you don't just reduce anxiety. You give kids their lives back.
No.
It's a heavy, complex topic, but ultimately, the data here is incredibly hopeful.
It is very hopeful, but it also demands that we look critically at the systems we blindly trust.
Oh, for sure.
And this raises an important question for everyone listening today, regardless of whether you're raising teenagers or not.
What's that?
If a simple, free 2-minute questionnaire can dramatically reduce the risk of a psychiatric relapse simply by catching what a rushed medical professional didn't have time to ask, what other simple, rapid diagnostic tools are we entirely ignoring in our own adult healthcare?
That is a fascinating point.
Think about your own daily wellness. Think about the last time you sat in a doctor's office for a 15-minute slot.
We've all been there.
What vital, defining parts of your own health story are being left out of your chart simply because the system doesn't take the time to ask you the right questions?
Wow. That is definitely something to chew on before your next annual physical.
Definitely.
Maybe you don't just need someone to point at the obvious symptoms on the surface. Maybe you need a system that is actually willing to wade into the muddy waters, look at your whole history, and ask the questions that actually matter. Thanks for taking the deep dive with us.